So patient name, Mrs. Subeda. She's 36 years old female coming from Pattambi. She came to the college OPD with a chief complaint of space in the front tooth region in upper jaw, which is increasing over time. The patient was referred to the Department of Clinical Periodontology and Oral Implantology for opinion and management. History of presenting illness. Patient noticed space in front tooth region in upper jaw since 10 years, which is increasing over time. Dental history. Patient has undergone orthodontic treatment with extraction of 15, 25, 35 and 45 12 years back. Extraction of 24, 25 and 46 due to caries 2 years back. Medical history, there is no known medical history and a patient have
She's undergone orthodontic treatment. Was it with a removable appliance or a
fixed appliance.
fixed appliance?
After that, she didn't use the removal appliance with fixed treatment.
How long did the treatment was?
1 year and a patient of one patient of 1 year.
So she had a short-term orthodontic treatment or a long one? No idea.
1 year on the patient, almost 1 year.
Okay. Was it for the same reason she had this problem? Was the orthodontic treatment done for the same reason, spacing in the anterior teeth?
Spacing plus proclamation as well.
So she had the same spacing in the anterior teeth with progressing spacing in the anterior teeth with proclination. For that, she has undergone an orthodontic treatment. Okay. And did the same thing relapse soon after removing the appliance?
Almost after 1 year, after removing the appliance, after 1 year, we started noticing the space again.
It's a lady, right? Lady. Was it anyway coinciding with her marriage or anything that she has done this ortho treatment?
Yes. She did the ortho treatment after she got married.
Did she underwent some pregnancy period or something during this period? Immediately after the orthodontic treatment or during the ortho treatment or something?
She got married after completion of orthodontic.
After completion of the orthodontic treatment, she got married. Then she had kids. Presently, she has got some kids. So during this phase, she has undergone a pregnancy period also.
After ortho treatment.
Then.
Photographs.
Something relevant, some relevant examination you have done for her pertaining to this complaint.
So she have a tongue thrusting habit.
I'm going to come back to it later. I'm going to mention all those things later. Are you going to come to it? Are you finished case history? Tongue thrusting habit is present. Yeah. Anything else relevant to this? What about overjet, overbite? Trauma of occlusion? Overjet and overbite is there? Or is it having trauma of occlusion? Teeth are in contact. The anterior teeth are in contact. So, trauma of occlusion is definitely there. So that means the lower teeth are going to push this upper ones. Plus tongue thrusting habit. You worsen it, right? Could have been the same thing when she underwent orthodontic treatment also. So tongue thrusting will result in bone loss in which region? Palatal side, interdental area, labial side, labial side. What about trauma of occlusion? Trauma is going to direct to which direction? Here, when the teeth comes in contact, the lowers are going to push the upper anteriors labially. So that itself is going to cause more labial bone loss. Naturally, consistently, there will be bone loss in the interdental area and palatal. After a certain amount of bone loss in the labial side, it's going to affect the interdental and palate also. So in those two conditions, like trauma of occlusion as well as tongue thrusting habit, is going to have a complete impact on the labial bone, which will result in labial bone loss. Now tell me, which bone will be lost when you do orthodontic treatment here? where will bone resorption result when you do orthodontic treatment for this case? You're going to put an appliance at the labial side and you're going to push it to the palatal side. Naturally, if it has to move to palatal side, then there has to be palatal bone loss. What will be the net result? Total bone loss. Habit will eventually cause bone loss in the labial side. A treatment, orthodontic treatment is going to cause it on the lingual side. Do you think there will be a position of bone on the labial side when this correction is applied there? When you have still tongue thrusting habit present during the orthodontic treatment, when you have trauma from occlusion present during the orthodontic treatment, do you think there will be bone apposition on the labial side? No, what will be the net result? This is the reason why orthodontic failures always comes to perio. Orthodontic treatment are all done at the cream age of the patient. The after effect of this is going to happen soon after that. Then, collectively, she underwent a marriage. She underwent a pregnancy period once or twice. How many children? One children also. Imagine what would have happened during that pregnancy period. As such, there is a possibility of gingival lesions during the pregnancy time. As such, it will be there. Resulting from what? Vomiting and acidic pH and all those things are caries related issue. Regurgitation causes acid, regurgitation causes saliva to turn acidic. That will result in caries. I'm not talking about that at all. That could be there, that need not be there. That's different issue by itself. Understood? Regurgitation causing acidity, causing demineralization, resulting in cervical caries, to be shown up after 5 years of the patient completing her pregnancy. That is another issue by itself. Whether that is there here or not, I'm not sure about it. But talk about the periodontal side of it. Which hormone? Both the hormones, but progesterone seems to be the culprit which will harbor one particular microbe in that region, which is seen more during pregnancy. Which one? Which microbe is seen more prevalent in pregnancy gingivitis? Resultant of increase in progesterone in the gingiva. Not just P. gingivalis. P. gingivalis is commonly present in any kind of gingivitis and periodontal lesion. Prevotella intermedia is seen increasing in number during pregnancy gingivitis. P. gingivalis is always present. Whether it is gingivitis or periodontitis, PG is always present. That will do its job. But P. intermedius is something which is more prevalent in your pregnancy gingivitis type. And that is seen exuberantly increasing its number in this particular condition. So just see a collective picture of all these things happening. Bone loss, which has already happened because of the habit present. Okay. Trauma from occlusion. On top of it, ortho treatment. Remove the appliance. By that time, both the bone would have gone. Both the bone from the labial and lingual and the interdental gone. Then she underwent a condition of hormonal changes. So collectively now environment has changed. So habit, environment, everything is now working against the periodontal disease. I mean, periodontal balance of retaining the teeth in position. So in every means, now it is vulnerable to a periodontal breakdown. Okay. Now, what has happened now? As of now, what is the condition? So because unless you have the understanding of this entire background, you cannot come into deciding on the prognosis of this teeth. Even if you happen to see some amount of mobility here also, you cannot restore it back to a stable level by any means. So first thing what we would like to check for it is the mobility of the teeth.
Anteriors.
Lower anteriors are seen mobile with one grade 2 and three of them having grade 1. What about the upper teeth?
1 and 2 1, grade 1 mobility.
Upper, the central incisors are grade 1 mobile. Now that means even after this much of assault, it is still there with grade 1 mobility. Would like to see the spacing. How much is the spacing between them? Clinical picture. It's a wide spacing. Wide spacing. So when you see a wide spacing, which is progressing, what does it say? Bone loss in the interdental area. When you see a spacing where teeth has been distally migrated, that simply says mesially there won't be a bone support. Distally there will be bone. For that only we check for the mobility. The mobility seems to be grade 1 alone. So with this much of movement to both sides, it's still grade 1. Are you sure about the mobility? Is it grade 1? Because a grade 1 with a reason can still be restored. So it's grade 1. It's moved quite a lot. Okay, so that's the condition. What about the other periodontal charting, whatever you have seen? You see multiple pockets there. See here. Deep pockets in the anterior region. So even the posterior, whatever is remaining, it has got deep pockets. So let's now first discuss the upper anterior sextant now. When you consider upper anterior sextant, it has got deep pockets over there. Can you explain? How will you explain that region between 1 4 to 2 3? In a very simple manner.
So in upper anteriors, there is pocket ranging from 2 to 6 mm.
Very good. So it is having multiple periodontal pocket. Let's make it clear it's periodontal pocket. Because pocket need not be always periodontal pocket. It can be gingival pocket also. So how will you explain it exactly? It is periodontal pocket. What is the basic difference between a gingival pocket and a periodontal pocket?
So below the gingival pocket is supra pocket. Supra.
So a pocket with dash is periodontal pocket.
Clinical attachment loss.
Yes, attachment loss. A pocket with attachment loss is periodontal pocket. As long as there is no attachment loss, then it is gingival pocket, pseudo pocket. Right? So are they periodontal pocket? Okay. So you have multiple periodontal pockets in the upper anterior region. You're talking about the upper anterior sextant alone, which should be from 1 3 to 2 3. Since you don't have a 1 5, probably you can explain, start explaining from 1 4 to 2 3 region, considering it as upper anterior sextant. That's all. Otherwise, sextant wise, anteriors are to be treated separately, posterior to be treated separately. For another aspect, somewhere some other specialities might name the different areas in the mouth in terms of quadrants. For a periodontist, it should be always in terms of sextants. So anterior region is totally a different one compared to the posterior teeth. posterior teeth are having multiple roots or probable furcation and all those things. The pathology in that region is totally different. Those teeth are meant for another purpose. Anterior sextant are meant for another purpose. Habit related problems like trauma of occlusion and tongue thrusting habit are more seen in the anterior region. The anterior teeth are not in contact and will be having sufficient overjet and overbite in the anterior region. Posteriors, there will be always in proper contact. Multiple point contacts are seen in the posterior teeth compared to single point contact in the anterior teeth. All these things have got a major role to play in periodontal disease progression. So anterior sextant, whatever is happening in the anterior sextant has got little comparison with the things happening in the posterior region. So when you call it a disease as such, we need to assess separately the anterior sextants and posterior sextants. That's why your flap surgery or any kind of surgery you do should be always sextant wise, not quadrant wise. Got it? The combined effect of many things, the combined effect of plaque related, habit related, all those, whatever you learn as neurosis, all those things will be more prominent in anterior region. Understood. So anterior should be treated separately, posteriors to be treated separately when you consider periodontal treatment. So always consider going in for a sextant-wise analyzing in periodontal case diagnosis. Understood. So in that condition, when you consider 1/4 to 2/3 region, it has got multiple periodontal pocket, ranging between what range to what range.
2 to 6 centimeters.
Okay, so some areas having 2, the maximum is 6. So that is well explained. So this particular anterior region has got a pocket ranging between 2 to 6 millimeter, means whoever it is to be communicated has understood. So it has got some deep as 6 and less as 2 also. So there are areas with 2 also. Am I right? Yeah. Then what else? Pockets. So ranging between this and
Deeper pockets are seen in the deeper pockets are seen in interdental.
yeah, deeper pockets are seen in the interdental region. So interdental region as the regions have got deeper pockets. Of how much?
3 to 6 centimeters.
Yeah, 3 to 6 millimeters. With deeper pockets in of 5 to 6 between
Central.
1 to 2 3 region. They are all having deeper pockets. So that means naturally very less area which are having no pockets in the interdental area. All the areas are having either 3 or 4 or 5 or 6. That means interdental areas are having deeper pockets. What about the labial side?
Labial side.
Least seen on the labial side with 2 to 3 millimeters. And the palatal side, slightly more in the palatal side of ranging between 3 to 5 millimeters. So what does that mean? Labial side pockets are very less. Palatal side it is more. Interdental area it's worse. This is the picture. So what has affected this patient more? Hmm? Yes, yes, yes. So now what is that? So majority of this thing is created by iatrogenically induced conditions. Hmm? So not a pathologic one or a disease progressed one. It is direct injury to the bone and bone loss. Could be the reason why there is less of mobility. Because pathologically induced plaque related one would have been more. But if you see these areas, it won't be having much of a visible recession on the palatal side. Are they? There won't be much of a recession on the palpal side. So the keratinized tissue is still retained. So there is always a chance of, yes, you said it. You can go in for a treatment, retain it as long as possible. If possible, go in for some kind of a treatment which will prevent its further progression of the flaring. In other words, this is a treatable condition. So for this to be treated, what should be your prime objective here? Forget about the other areas, just the upper anteriors. What will be your objective in treating this case? Objective is what? Hmm? Yeah, you're going to do something which will attain something. I am going to climb to the first floor, then to the second floor, so that I'll reach perio. So climbing first floor, climbing second floor. Naturally, I'll reach perio. So my aim is reaching perio. My objective is climbing to first floor and second floor. Whether I climb or not is a different thing. But first floor has to be accomplished. Second floor has to be accomplished. Then I'll reach perio. Whether I climb up by any means or whether I take an elevator, escalator, that's all different thing. But these two landmarks I have to cross and reach here. Similarly, what are you trying to do? What will you achieve? In simple terms, what is your aim here? What is your objective?
Healthy, maintainable periodontal.
Very good. Aim is always in a periodontal flap surgery or all these kind of things what you do. Aim is always the same, which very people understand, which are set in textbooks, but very less or it has not been very prominently projected that the aim of periodontal disease is what you said. Mhm. An easily maintainable state of periodontia. Actually, this is the aim. In simple words, even if you don't brush, even if you don't use any other brushing or any cleansing aids, your teeth should be always clean. To make it more clear, your teeth should be like animals. Strong, good, and clean. No brushing needed. That is the best periodontia. I said strong, it should not be mobile. It should be clean, nothing on it, even without brushing. Which is possible or not is a different thing, but it's always your aim. So what are the things that is hindering it from getting it now? What are the things that is what are the hindrance to achieving that aim? This person will always have a very diseased gingiva and always some kind of deteriorating periodontia. Hmm? In this present condition. So your objective should be something. Your objective should be something very much tailor-made for this case, which will ultimately help you to achieve your aim. Health of gingiva, health of periodontia. What are the things that is hindering right now? One thing I'll tell you, a mobile teeth can never be clean. Straight away. So whatever you aim at should reduce or eliminate mobility. A tooth, if you have a mobile tooth, that tooth as well as the nearby tooth as well as the area is gone. You won't be able to chew it properly. You won't be able to chew there properly. That will definitely result in periodontal loss. So mobility should be gone. Then trauma of occlusion, all those things should be gone. So that will ultimately result in lesser mobility itself. So mobility should be gone means methodology means what? Objective, if you fix your objective in reduction or elimination of mobility, then your methodology will be trauma reduction, tangstress habit reduction, all those things will come in between. Then
Pocket elimination, pocket elimination, bone
pocket elimination, all those things. Can't you put the whole thing under self-cleansing? That area should be made self-cleansable. That area should be made self-cleansable. To make it self-cleansable, you need to do a lot of things. So your prime objective for this case is going to become self-cleansable area. Self-cleansable, self-maintainable area. That is your aim. Now, coming into the wider objective of it. How will you achieve a self-cleansable area? Self-maintainable, self-cleansable area. What only will you do? Eliminating the trauma of occlusion, tongue thrusting habit, and all those things. Will you be able to do some kind of a treatment for tongue thrusting here? The textbook said whatever is taught to you to treat trauma of occlusion, tongue thrusting habit is some kind of a punishing appliance. Right? That's the only thing which we have heard about how to treat tongue thrusting. See, forgive me, that won't work. That won't work. You're going to give an appliance of punishing at the age of this, which you have already destroyed that periodontium and kept. On top of it, if you are going to give some kind of an appliance for this case and all, I don't think it's going to work. So that part is gone. So what else could be tried? Think in a very wise manner and say. Tongue is going to push our anteriors to front. Definitely, tongue is going to push it front. Can you do something which will withstand this extra tongue pressure? Implant. No, withstand because it's just grade 1. We are going to treat it periodontally, like we already decided. Yeah, if you can apply, if you can give sufficient pressure to withstand the tongue thrusting habit, then definitely the tongue thrusting cannot progress. This have been tried always throughout. If you see the history of this treatment for this, they have all tried splinting. They have all tried splinting. Splinting of teeth to prevent tongue thrusting from progressing, which will prevent it from flaring. They have tried splinting. But here, splinting will worsen the condition by giving more areas hindrance for your maintenance. Definitely, that's going to create more problem. There is a tongue twisting plus trauma occlusion also. Your lower incisors are going to touch your splint on top. That's going to worsen the condition. So splint is not going to work here. Then something else. You should consider an FPD, connecting the anteriors. Connected crowns can be tried. It might look very crude way of managing it, but tell me another option. Doing root canal treatment for all the anterior teeth and then connecting all with good crowns. Do you find it very odd when you have to do root canal treatment for 6 teeth or 6 or 7 teeth, connecting it with crowns? Doesn't it look odd? Okay, then tell the other option. Ask the patient to be like this for the rest of their life. If it is in your mouth, that is the only way you should be thinking. If it is in your mouth, you're got a flared teeth, proclaimed teeth, asking you to live like this for the rest of your life. Will you agree to it? If you don't agree, then your patients also won't agree. If you do agree to it, then your patients will also. Simple as that. Any confusion, I've already always told you, anything like this, if you go confused in any time, think it is you. Even otherwise, you should be thinking that the patient is not different from you. So think in terms of you. If it is your mouth, you've got to flat teeth. And just because you've got to do some kind of a treatment like root canal and crown and all, you're not ready to do all those things. Okay, then you will live like that. You need to apply sufficient strength or to withstand the tongue thrusting habit. Only thing is you going for an FPD, connecting all the teeth. Or you're not agreed to do it. Okay, don't do it. So that is the only aspect. Then for that, what need to be done? Root canal treatment, crown and all those things. Okay, keep it aside. That is later. To withstand the tongue thrusting habit, now you got an idea this can be done. Otherwise, what was the idea? Tongue thrusting habit. Come on. That's not going to work. That's not going to work. We'll discuss with the orthodontic people. We have already discussed a lot of cases. Such a periodontal broke down case, if you go to apply some kind of an appliance here to prevent it, that's going to worsen the condition. So you have fixed it with tongue thrusting is to be managed by FPD. So let it be there in the mind. So that is to be done later. So periodontal pockets, how will you manage it? I'm going for the textbook way of managing periodontal pocket. You got a chapter on periodontal pocket surgical procedures. Surgeries to manage periodontal pocket. It is there. What are the surgeries said in it? You have got techniques ranging from excision of the gingiva. You have got techniques that will reduce the pocket. We have got techniques which will eliminate the pocket. Reduction of the pocket starts from a simple scaling. Do a thorough scaling, that will also reduce the pocket. It will come back. Hmm? Lining of the pocket can be removed. Soft tissue wall of the pocket, that is curettage. It will reduce the pocket. But that will be like, it will come back. Because you have not done the ultimate treatment of eliminating it. The perfect, the most eliminatable way of doing a pocket therapy is which one? Which is that procedure which will give you a complete elimination of pocket? Gingivectomy. There's a pocket, you cut away the pocket, finished, gone. So the most performed gingival periodontal surgical procedure of one time was gingivectomy. Complete gingivectomy of the pocket area. Pocket is gone. But a complete gingivectomy will completely eliminate the pocket, but it will not allow anything further than that. Okay. In other terms, your objective is not just eliminating the present pocket. We need to re-establish that area which will prevent further formation of pockets. You understand? To prevent further formation of pocket, we need to re-establish one thing of gingiva. What is that? Yes, contour. Contour has to be re-established. If a gingiva has to be contoured back to normal, which is, what is the normal contour of gingiva? Scalloped with knife edge marginal gingiva. The underlying bone also has to be in the same shape. If you have a bone which is rounded off, if you have a bone which is has haphazardly distributed crustal bone, the gingiva overlying it also will be the same. My face is like this because my skull is like this. My jaw is like this because the shape of my mandible is like this. You shape the bone, the gingiva has got a chance to become well contoured. Your bone is going to be rounded off. Your gingiva will be rounded off. That will again be a hindrance to a normal cleansing mechanism while chewing. Gingivectomy cuts off the gingiva but will not allow you to do any kind of a bone surgery underneath it or bone contouring underneath it. Gingivectomy will result in a mass destruction of the keratinized mucosa because the very excision is external bevel. So from curettage, pocket reduction, to gingivectomy, complete pocket reduction or complete pocket elimination, but nothing else can be done. Complete keratinized mucosa is gone. Bone reduction cannot be done. A wide range of tissue will be exposed and kept. Postoperative discomfort, patient morbidity increases. So came another surgery, that is your flap surgery. Among the flap surgery, you got one pocket reduction surgery, which is modified Whitman. Then you got the most celebrated, the most widely accepted, universally accepted pocket elimination flap surgery, that is undisplaced flap surgery. Then you have got another surgery which has got an objective itself of retaining the keratinized mucosa, getting the result of undisplaced surgery. That is apically displaced flap surgery. Modified Whitman flap surgery will retain the keratinized mucosa, but the net result will be pocket reduction with a chance of further pocketing in future because of the outcome being long junctional epithelial formation. Undisplaced flap surgery is otherwise known as an internal bevel gingivectomy, will remove considerable amount of gingiva, keratinized mucosa, but pocket will be eliminated. Apically displaced flap surgery will retain the keratinized mucosa and give you the result of undisplaced flap surgery. You got this? Yeah. So there is the equal possibilities of gingivectomy and flap surgery. So flap surgery being found to be superior for the reason you're not going to sacrifice much of your keratinized mucosa. That is the thing. And now when you consider flap surgery, the main advantage of a flap surgery is the beautiful internal bevel incision. Internal bevel incision, which incorporate every goodness of curettage, preserving the keratinized mucosa, and most importantly, equally giving so much importance to the crust of the gingiva, which will be thin as possible. So the objective of internal bevel incision are these three. A complete removal of the pocket lining, sharp marginal gingiva, preserving the keratinized mucosa. Okay, all these three flap surgeries have got the same kind of internal bevel. Only thing, position varies. Now, since you are having these many pockets in the interdental area, you have got more pockets in the interdental region. Deeper ones on the palatal side, lesser one on the labial side. Are you going to aim for, or are you going to consider modified Whitman here, or undisplaced here, or apically displaced here? Here, when you see the anterior regions have got lesser pocket, but what about the attachment loss? Attachment loss is also more on the palatal side, less on the labial, because that has to be considered. Right? That has to be also considered, not just the pocket depth. Pocket depth is measured from the crest of the pocket to the base of the sulcus. That has got nothing to do with the CEJ. Attachment loss has got a measurement from the CEJ to the base of the sulcus, which is quite less here. On the labial side, it is less. Palpal side, it is more. So you are going to get much of the pockets with attachment loss on the palpal side. Not an easy area to put internal bevel and all those things, mind you. This is not at all an easy case. You're aiming at undisplaced. It's not an easy case at all. But when you're considering modified Whitman or apically displaced, the incision is internal bevel incision with reference of marginal gingiva. Undisplaced is the reference of base of the pocket or pocket base. Undisplaced flap surgery has its reference of base of the pocket. Whereas for modified Whitman and apical displaced, the reference is crest of the gingiva. See, which is easier is not the question. Which is most suitable for the patient, for that person's problem is the choice. It's because you can do an easier surgery which doesn't give you the right result for the patient, then that should not be the choice. But here if you see, it is attachment loss of, less of attachment loss in the labial side, but bit more in the premolar area. Okay, fine, whatever it is. Anyway, you've got 3 to 5 millimeters in the palpal side. An interdental area which you have already shown is having deeper pockets also. Considering all these things, what will be your flap surgery of choice? One name out of these three. Is it eliminating the pocket or reducing the pocket? Eliminating. So you have already summed it down to two: apical displaced or undisplaced. So come to your choice. Come on. Why? Why apical displaced? Anterior region agreed. Attached mucosa. Gingiva. Gingiva. Attached gingiva will not be lost in undisplaced flap. Be very clear with it. Pocket will be lost. Keratinized mucosa will be lost, not attached gingiva. That is the reason why it is called undisplaced. See, the word undisplaced means it will look to be displaced, but it is not. That is the reason. When you call something that is unmoved, that means actually it looks to be moved, but it is not moved. Actually, that thing would have moved, but it has not moved. Otherwise, you can just say it is still. When you say that thing is actually, when you say that is not black, that means it may be looking like black, but it is not black. That is the meaning. When you say this glass is not, when you say glass is not ceramic, that means this glass might appear to be ceramic, but it is not so. Similarly is the term undisplaced. It looks to be having displaced, but it is not. That's why it's called undisplaced. Otherwise, it would have been called non-displaced. It's not non-displaced. It's undisplaced. The very term says it might look otherwise. Understood? So, an undisplaced flap also will excise keratinized mucosa. But attached gingiva will be still there. Because your reference was base of the pocket. Base of the pocket is not attached gingival area. It is free gingiva. You are excising free gingiva. But keratinized mucosa will be lost. Apically displaced flap has got one advantage of, yes, increasing the zone of attached gingiva. Not retaining the attached gingiva. Increasing the zone of attached gingiva is one surgical advantage of apically displaced flap surgery. Considering the amount of attachment loss, you should be considering retaining the attached gingiva there. Since you are going to do a procedure of RCTs and the crowns, all those on this teeth, which is yet to come after your flap surgery, there will be good amount of gingival shrinkage. Pockets will become visible. You have certain amount of pockets here, like 6 millimeter, 5 millimeter, and all. That means the roots are still not visible to the naked eye, but they are visible to rest of the things, including micro. But your 6 millimeter, 5 millimeter of pocket says your root is not visible right now. There is a flap covering barely the root surface, and there is a pocket inside it. Once your flap surgery is completed, that gingiva is going to shrink. Then your root will become visible to the patient as well. You get this point? But your pocket will be disappeared forever. Your pockets will be eliminated forever. I do agree to what you said. With an attachment loss of 3, 4, 5, then again, yeah, 3, 4, 5 range and all. That means good amount of attached gingiva is already lost. Attachment loss is from CJ to the base of the sulcus. So that means good amount of attached gingiva is already 3 or 4 is already lost. 3 is very much general. 3 millimeter is gone from everywhere. So whatever is possible to retain, you should be retaining. You don't need to worry about the palatal side because palatal has got abundance of attached gingiva. The whole gingiva on the palatal side is attached. But labial side, you got 3 to 4 millimeters of attachment loss. So considering apical displaced flap surgery is not a bad idea. Do go for it. Okay, then how will you go about it? Incision is same as your modified Woodman incision. The crust of the gingiva is to be considered here. From the crust 5.5 millimeters, 0.5 millimeters apically, you need to mark an incision line throughout the gingival margin. Take how much ever time you want. Your internal bevel incision should be so perfect. With that incision, mucosal, the pocket lining should be gone. A very thin, beautiful, sharp marginal gingiva has to be re-established. Very little amount of keratinized mucosa should be sacrificed. All those 3 objectives should be achieved with that one incision. Take your time. Do the buccal side first. Achieve a very good drawing with your incision. Your incision should look in such a way that it is all throughout the gingiva. It should be 0.5 millimeters apical to the crest. Just 0.5. 0.5 is so less. And that blade should go and touch the crest of the bone, not to the tooth. So ultimately, you will get a very thin gingiva. Go for the palatal side. Same way. It should be like a pencil drawing. 0.5 millimeter away from the crest, incision touching the crest of the bone on both the sides. Now you have separated out the pocket lining. Right? Elevate it. Elevate the gingiva, you have kept it separate. Elevate it. How much do we need to elevate it? Just separate it from the incision area. Just separate it. That's it. Then you go in for your sulcular incision of the excised portion of the gingiva. Sulcular incision throughout. So that has separated out the excised and kept portion. Since you elevated it a little bit, you will get access to the interdental areas. Put an incision excising the interdental area of the excised portion of gingiva. remove the tissue with the curette. Your surgery is over, almost over. So your whole concentration is on eliminating the pocket. Here it is particularly eliminating the pocket lining. Okay, clean it up completely. Then go for a complete elevation of the flap beyond the mucogingival junction. A vertical incision is not mandatory for apical displaced flap. If you can displace it apically without vertical incision, since you have got a wider area, this is possible. If it is not possible, going for vertical incision. Since it's an area covering from 1/4 to 1/3, sorry, 1/4 to 2/3, you might not need a vertical incision here. Might not. If you need it, put it. Otherwise, no need. So you are going to elevate it beyond the mucogingival junction only to suture it to the bone tooth interface. So when you elevate it, see for the bony ledges and craters. So internal bevel, elevate it a little bit, sulcurar incision, interdental incision, remove the tissue and finish it up. Once that is done, your bleeding part is gone. All your bleeding comes in the area which you have already excised and thrown off. Your granulation tissue and all will be in the incision done area. Your flap will not have anything to bleed unless it is fresh bleeding area. So by the time you have completed these 3 incision and removed the tissue from the pocket area, your bleeding will automatically stop. Then elevate the flap to the mucogingival junction, beyond mucogingival junction. Then you'll get an access to the underlying bone. Shape it up well so that once you put it back, your contour of gingiva will be knife-edged, flat. With scallop. I would add one more term to that, which need to be, oh yeah, that comes automatically, festooned. The interdental bone should be shaped in such a way that it will not be a bulbous tissue. Interdental bone on the labial side should follow the root curvature. That will make it look fantastic. Festooning. Scallop the gingiva, marginal tissue flat. Bone should be made in such a way that it will harbor the normal gingival tissue with some amount of festooning on the labial side of the bone. Fantastic it will look. For maintenance, it will be good also. That is the one of the steps of osseous recontouring surgery, cystic osseous surgery. Which is that step? Vertical grooving, then this is the radicular blending I'm talking about. Radicular blending of the bone, which will correspond to the root underneath it. It will give a proper harboring of the mucosa overlying it. Got it? So gingival contour, gingival shape, everything one side. Bone. Contour the bone in such a way that it will harbor the thinnest possible gingival margin, plus the interdental area will be festooned also. Do all those things. Suture it to the bone tooth interface. Pocket eliminated. Root will be visible, which was otherwise visible for microbe, everything inside the pocket. Now it will be made visible for everybody. You understood? Before it was pocket when you chew some food will go inside and stuck into the pocket area. It will not clean it. Now it is exposed. It will naturally clean the teeth as you chew itself. That's what we are going to achieve out of it. So keep a nice preoperative photograph. All the steps starting from incision, first incision, second incision, third incision, after raising the flap a little bit, raise the flap, do the bone contouring, do the suturing. taking any amount of time is welcome at this point of time. But always remember this entire anterior region should be completed within 45 minutes maximum at some point of time of your life. Right now, how much ever time you take, I'm not much bothered about it. But definitely, if you take more than an hour in later, I'm definitely concerned. Because this has got certain steps of doing it, which are in many ways so well pre-planned. You can do it so pre-planned that it should not take more than 10 minutes time. Is that clear? So all those steps have been photographed and we'll have a review of each of those steps and what you have achieved at the end of the surgery and we'll review it. Okay?